morning, everybody. So as the title shows, I will be talking about the same mumps outbreak in Lebanon that Nadine just spoke. But unlike Nadine, I will share results of the retrospective cohort study in a school context. A small background about Lebanon. Lebanon lies in the Mediterranean region, and as you see from the map, it is bordering Syria from the north and eastern part, and bordering occupied Palestine from the southern part. And within the territories of Lebanon, Lebanon hosts a Palestinian population, as well as most recently Syrian displaced population, with a total population combining all three reaching to 6.2. As Nadine already said, I'm just going to repeat a little bit. We have a Lebanese national calendar where the mumps vaccine is included in the MMR vaccine, mumps, measles, rubella. And as for the first dose, it is administered at the 12 months. And for the second dose, it is administered ever since 2014 at 18 months. However, before 2014, it was administered at 4 to 5 years of age at school age. As for the coverage, again, just a small refreshment. In 2014, the administrative data has reached 69% as compared to UNICEF and WHO estimates reaching around 75% in the same year. Now, in Lebanon, as I already mentioned that we have the Palestinian population, they follow a different vaccination calendar that is followed by the UNRWA, United Nations Relief Works Agency for the Palestinian refugees, and they only administer one dose of MMR at 15 months. And their coverage has been estimated to be 99% in 2014. This is used via rapid assessment technique, as they already informed us. Now, a little background about the mumps outbreak that Nadine already explained thoroughly. This is the epicurve of the outbreak, depicting here the weekly count of reported cases for the past 5 years. Again, you see the magnitude of the outbreak. As for the distribution of cases, we look here at the incident rates of mumps by province in 2014. As you can see in the map, that the most affected provinces are Bekaa, North, Beirut, Mount Lebanon, following Nabateeh, and South. Looking at the age-specific mumps incident rates in Lebanon 2014 in this outbreak, you can see that the age group with higher incidence is the 5 to 9 years, as well, followed by the 10 to 9 years age group. And this is nothing but just a summary of what is called the school children age group. So from here, we decided to conduct a study in the school context to understand better the outbreak. So the objectives of our study was to measure vaccine coverage and determine mumps vaccine effectiveness in a school context in order to provide decision makers with evidence-based recommendations to prevent future outbreaks. For the methodology, we conducted a retrospective cohort study in a school context, as I already said, and the study population were all registered students in the participating schools from preschool grades to high school. So the process of selection of participating schools is that the Ministry of Public Health is being reported to about mumps cases from a variety of reporting sources, from which are schools, hospitals, and dispensaries. Then the Ministry of Public Health will verify and investigate these cases. And if we get to know that these cases they go to a same common school, we contact that school and we check if there is more than 10 cases in that school and the school is willing to participate, it is being selected and it is being enrolled in our study. So the data collection methods, we had two, the line list and the structured questionnaire, and actually we gave the choice to the school to choose between these two data collection methods. For the line list, a team from the Ministry of Public Health would go to the school and look at the available students' health records in the school and fill the line list. And whenever that we didn't have information, we would take the phone number of the parents and call them and fill our information. As for the structured questionnaire, we had a consent form included in the top part of the questionnaire. It was administered in Arabic, and it was distributed to all parents in the school, not only to those only with cases. As for the collected data, we collected demographics, age, gender, nationality, vaccination status, and specifically we needed the dates of the doses for the MMR doses and disease status ill, not ill. For the cohort study, for certain definitions, exposure. Being exposed, vaccinated, is a student with available dates of MMR doses, and that a student with no available vaccination dates, he's being non-vaccinated. As a disease, a case is being a student having had mumps during the 2014-2015 scholastic year. For the data management, we used EpiData for data entry and Stata version 13 for data cleaning and analysis, using the following formula for calculating vaccine effectiveness at 95% confidence interval. Now, what about our results? The participating schools by provinces, we have selected 7 schools, 5 Lebanese schools and 2 Palestinian schools. As you can see, we have in the north of Lebanon 3 schools, 2 of which are Lebanese schools and 1 was from a Palestinian school. In the Bekaa, 2 Lebanese schools. In Mount Lebanon, 1 Lebanese school, and in Beirut, 1 Palestinian school. And the response rate for the cohort was 72%. Now, for the proportion of cohort age group and the percent attack rate, you can see that from the first graph, the mean age of the cohort was 10 plus minus 3.4 years, and the majority of the participating students were in the age group of 10 to 19, followed by 5 to 9 age group. Regarding the attack rate by the age group, you can see that they are somehow comparable. 0 to 4 years of age is 14%. As regarding the nationality, the majority of the participants in our cohort were Lebanese, 74%, followed by Palestinians, 22%, and Syrians, only 3%. As for the distribution of cohort by gender, the majority were males, but here I'd just like to highlight the fact that one of the schools was all males, constituting around 20% of the total cohort. Now we calculated vaccine effectiveness, and we calculated the MMR coverage for each dose for the whole cohort, with a total number of participants reaching 3,287 after those who responded. So the coverage for the first dose was 31%, with a vaccine effectiveness of 37%, ranging from 22 to 50% confidence interval. As regarding to the coverage of the second MMR dose, it reached 17%, with a vaccine effectiveness of 54, ranging from 35 to 67. Now here, since I already mentioned that we already have Palestinian schools and Lebanese schools, and also since the Palestinians, they follow a different vaccination calendar, it was more logical and wise to segregate our analysis and look at the Lebanese schools alone and the Palestinian schools alone. So we're gonna look now about for the 5 Lebanese schools, with a total number of participants reaching to 2,440. And the coverage of the first dose was 43%, with a vaccine effectiveness reaching 53%. As for the second coverage for the second dose, it reached 23%, with a vaccine effectiveness reaching 57%. Now, what about the numbers for the Palestinian schools? Only 2 schools, with a total number of respondents with reaching 847. The MMR coverage for the only 1 dose administered was 61%, with a negative value of vaccine effectiveness and insignificant interval, 95 confidence interval. We conducted an awareness session with the help of the expanded program of immunization. We went, a team of the Ministry of Public Health from the ISIUMO and the API program. We went to that school and we conducted an awareness session, because after we contacted the school principal, we found that the awareness was a little bit low. So we distributed brochures in Arabic for the parents, talking about the disease, the transmission, symptoms, prevention, and we promoted the importance of vaccination. As any other study as well, we have our own limitations. The ascertainment of cases. Most cases in our cohort were suspected and not lab confirmed. And again, we have this misclassification bias due to the fact that we have a good number of mumps cases that can be asymptomatic. Again, we have another limitation, which is the ascertainment of the vaccination doses. We didn't have the vaccination card. Despite the fact that we already requested that from the parents in the questionnaire, that please send us a copy of your vaccination card along with the filled questionnaire, but only few have sent it. So we couldn't just understand and make sure that what we have documented in the questionnaire is really of good quality. And as well, we had the misunderstanding that Nadine already spoke about between the measles and the MMR dates, because we saw in several of the questionnaires people mentioning or parents mentioning that they have more than 3 MMR doses, and it was not. When we contacted them back and we told them to read, it was a measles and not MMR. So there's a question mark about the second dose being MMR or measles. And we had a funny limitation with being that the children or the students being themselves filling the questionnaire, and that was obvious from the handwriting. So this is, again, a quality issue. And again, and last but not least, is the selection of schools. This is a convenient sampling. They were reporting to us, and we were enrolling them. So this might be. As a conclusion, as you already see from our result, that there is a lower than expected vaccination coverage for both doses. And there's a question about the effectiveness of the vaccine, with second doses not reaching the expected values found in the literature. This is one. 2, again, we mentioned something about the misclassification bias, with some cases being asymptomatic, that leads to somehow the negative values in the vaccine effectiveness, or it might be due to cold chain problem. There's a question mark we need to further and investigate. So as for our recommendations, based from our conclusions of the study, we recommend to enhance the routine vaccination. We recommend as well to improve the proper documentation of the students' vaccination card in schools, because we couldn't find them at school when we went over there, despite the fact that there is a law in Lebanon that requests from schools not to accept students and not to register them before providing their vaccination cards. So we need to enforce this law. And we need to we recommended to introduce a second dose of MMR for the UNRWA vaccination calendar. And actually, this is what happened. And from our preliminary results, we contacted our colleagues in the UNRWA health officials, and we shared with them our results, and they effectively and immediately introduced a second dose of MMR in their calendar starting June 2015. And we also discussed with them that the probability of there might be a problem of vaccine cold chain, so for also to go and consider it and check it as well. I need to thank you all for your attention and acknowledge all those who helped me in the study, mainly the participating schools. Without them, we didn't have our results, and the UNRWA health director and all the people helping. Thank you. Any questions?
Thank you very much for your nice presentation. Any question, please?
I was considering the lower than expected vaccine effectiveness, and you attributed that possibly to be due to cold chain problems. Couldn't it also be a misclassification?
Yeah, exactly. I mentioned that it might be to both misclassification bias and
because that would explain both the low vaccine coverage and the lower than expected.
Exactly, 100% correct. Thank you.
Thank you for your presentation. Actually, I was interested about the EPI and scheduled vaccination in Lebanon, that UNRWA only give one vaccine at one dose of vaccine MMR, and the rest of Lebanon give 2 doses. That I believe this issue should be resolved at Lebanon, that UNRWA should give also 2 doses of MMR in order to have a good immunity of our children and children there. And also, I'm wondered about your study. You said about the vaccine effectiveness, and at the same time, you said that there's no cards that you could see the students and no lab confirmation. So you just depend on the odds ratio in order to say about vaccination effectiveness in your study.
Okay. First, regarding your first question regarding the one-dose administration of the Palestinians in our country. As I mentioned that they used, from ever since 1996, they used only one dose. So as per our recommendations, we requested them to adapt and change their vaccination calendar, and this is what actually happened. So now, ever since June 2015, they will be giving 2 doses. This is one. 2, regarding the vaccine cards, actually, we didn't have a vaccine card to validate what's already written in the questionnaire. So the mother would fill the dates of the doses, of the first dose and second dose, but we could not validate this with a card. We already requested to have a copy of their vaccination card, but they didn't. Only few just sent us. So this is how, but the vaccine effectiveness was calculated. We had dates of doses, MMR1 and MMR2. I'm not sure. According to what the mother has provided, yes.
Based on what the mother is right in the questionnaire.
Because she would look at her card, the children's card, and document in the questionnaire and send it back. But we didn't have the card with us, but although we requested that. So we're counting on the mother's conscience to fill it correctly.
Okay, thank you.
You're welcome.
Any other question?
I just need to, I need to add for doctor from Egypt specifying regarding the genotype. I didn't mention it in my study because it's separate, but we really collected specimens from cases, and it turned out to have genotype G. So just for your information.
Oh.
Yeah, sir.
Okay, thank you for very interesting data and presenting very well. But I'm interested how MMR2 was higher than MMR1. Maybe one. MMR2 was about 54% and MMR1 30 or something.
MMR1 for the total cohort was 17.
No, at the end you showed that.
This one. The MMR1 was 31% and the MMR2 was 17. Let me see, this is maybe in the conclusion, you mean? MMR2, 54. This is, I believe, let me see, the Lebanese cohort. I believe, sorry. This is, I took the Lebanese cohort here. 53%, is it right, 53? Conclusion, sorry. It's typing mistake, sorry. The second dose is less than, but this is a typing mistake. Exactly, sorry, it's a typing mistake. Because it's here. It should be less. Thank you.
Other questions? No more questions. Thank you very much.